Welcome to Disc 3 of Know Your Meds, a system for safe medication administration. In this section, we're going to talk about how to avoid complications of anti-inflammatory medications. One of the things I often tell nurses is, if there's one thing in your entire career that you could learn more about the inflammatory cascade. The inflammatory process that occurs in the body is responsible for many of the different symptoms we see, and many of the disease processes that your patient will have are the result of or stimulate the inflammatory process. If you know about inflammation, it's much easier to care for all of your patients. Well, in a nutshell, the inflammatory process is going to cause three things to happen. It's going to cause your patient to have vasodilation, capillary permeability, and clotting. Now, these things make sense on a local level. Say, for example, you have a cut on your hand. If you have a cut on your hand, you're going to get some vasodilation in that area. That's going to cause it to become red and swollen. You'll have capillary permeability, and that's what's responsible for the drainage. And lastly, you'll have clotting, well, hopefully, so you stop bleeding, right? Clotting also helps to wall off the area so that bacteria can't get into the bloodstream and cause sepsis. Now, these three components of inflammation are very useful when they're local. The problem occurs when we have inflammation that is out of control, or inflammation that has been initiated inappropriately. Inappropriate inflammation occurs during atherosclerosis. So your patient who has developed cardiac disease has done so as a result of having inappropriate inflammation in the vasculature. Now, we think this process probably begins somewhere in early adulthood when we have an infection. And that infection causes an irritation of the inside lining of the blood vessel. That irritation then causes an inflammatory response locally in the vessel, which is what starts the atherosclerotic process. So often we hear so much about fat, don't we? LDLs and HDLs and cholesterol and all those things. But don't you know somebody who's really got horrible cholesterol levels and doesn't have any cardiac disease? Haven't you heard of those kind of people? See, it's not just the fat. It's not like you went to McDonald's one too many times and a French fry got stuck in your coronary artery. What's happening is there's an underlying inflammatory process, and that is what makes the vessel wall rough and allows those fat molecules to be able to bind or to start to form that fatty plaque. Now, inside the fatty plaque, there is an area that continues inflammation because it becomes necrotic. So there's a necrotic core, and that necrotic core continues to maintain inflammation in that area, and that's why atherosclerosis gets worse. An example of an inflammatory response that's out of control is sepsis. As a matter of fact, you may hear sepsis referred to as being sepsis syndrome. This is recognizing the fact that there is a syndrome of events that occur, and these are all related to inflammation as a result of sepsis. Now, we get similar situations occurring also when a patient has multiple injuries or a patient has ischemia. Your patient who has an ischemic limb, for example, or maybe a patient with an ischemic bowel, that generalized ischemia in a large part of the body stimulates the same kind of out-of-control inflammation that we get from bacteria or a bacterial toxin, which is what causes sepsis. It's this stimulation that then causes an out-of-control inflammatory response throughout the entire body, and that's the thing that we call sepsis. So inflammation, in fact, is helpful when it's localized, but when it becomes out of control or inappropriate, then we get disease processes associated with it. In the case of atherosclerosis, we have this abnormal formation of this fatty plaque inside the vessel, which narrows the vessel and then eventually is going to cause ischemia, injury, and necrosis of the heart or the brain. In the case of the sepsis syndrome, and again, I mentioned syndrome because it could also be caused by an ischemic event or injury. In those situations, we have an inflammatory response that's out of control. So this inflammatory response is throughout the entire body. Now just imagine that. You have a patient who has vasodilation, capillary permeability, and clotting occurring throughout the entire body. Now that response is so large that the body can't control it. Now you see, if you have a cut on your hand, that inflammatory response is well controlled. You don't go into sepsis and septic shock from that. It's a well-controlled inflammatory response. But when it's out of control and throughout the entire body, then we have what we call the sepsis syndrome. The massive vasodilation will end up causing shock and hypotension in your patient. The capillary permeability allows fluid to leak out of the vasculature, and the patient actually becomes hypovolemic. In addition, that leaking fluid out of the vasculature causes swelling in all of the organs, including the lungs, so we get pulmonary edema. In the brain, we get cerebral edema, and all the other organ systems, and that's one of the mechanisms that leads to multi-organ dysfunction. The third component was clotting. We get millions of tiny little microclots occurring throughout the patient's entire body, and that causes additional dysfunction of organ systems. So when inflammation becomes out of control, it can have very damaging effects on the patient's body. In fact, it can cause what we call multi-organ failure or multi-organ dysfunction syndrome. Inflammation is redundant. There's many different controls involved in maintaining inflammation and beginning inflammation in the first place. And this is a good thing. If you get a cut on your hand, you want to make sure you're going to have inflammation. Otherwise, you may not stop bleeding. Otherwise, you may become infected. Otherwise, the area may not heal. So it's important that there are redundancies to the inflammatory process. Now, what does this all have to do with anti-inflammatory medications? Our anti-inflammatory medications are designed to control some part of this inflammatory process. Because we don't want to be without inflammation. And now just imagine that for a moment. If we had a drug that was able to turn off inflammation, then if we did get a cut on the hand, or we did encounter a bacteria, or anything else happened to the body, we would not be able to repair it. We may even die from a simple cut on the hand. We would bleed to death and probably become massively infected. So it's important that inflammation continue. We're just trying to find ways to control inflammation in certain parts of the body. One of the types of medications that's very popular now is the non-steroidal anti-inflammatory drug. As the name implies, this is not a steroid. Okay, now let's make a distinction here. When we talk about steroids, we're not talking about the anabolic steroids that you hear so much of in the news with our athletes. We're talking about steroids that are naturally occurring in the body. Glucocorticoids and corticosteroids. These are the things that work in the body to help to maintain a lot of the different body functions. And we need to have these in the body. The problem with using steroids, as we'll get to later, is that there are a lot of side effects of steroids, and steroids tend to shut down too much of the inflammatory process at once. So, there was the development of the non-steroidal anti-inflammatory drug, the NSAID. Non-steroidal anti-inflammatory drugs control inflammation by a part of the mechanism of the arachidonic acid cascade. This is part of our inflammatory process. Typically, most drugs that we consider to be non-steroidal anti-inflammatories are going to affect the COX-1 arm of the arachidonic acid cascade. COX stands for cyclooxygenase, and this is one of the mediators of inflammation through the arachidonic acid pathway. One of the other mediators is COX-2. Whether or not there is a COX-3 or COX-4 or even COX-5, we don't know. But we have identified COX-1 and COX-2. The vast majority of medications we consider to be NSAIDs, and these are medications like Motrin, Advil, the generic is ibuprofen. The vast majority of these medications affect primarily COX-1, maybe with some secondary effects on COX-2. Now, COX-1 and COX-2 work on the inflammatory process from a couple different angles. In other words, they don't do the same thing. Our diagram on page 10 in your handout may look very simplistic, and you may think, well, geez, it looks like they're doing the same thing. They're affecting this arachidonic acid pathway in a couple of different ways. In other words, COX-2 inhibitors will have a different kind of effect than COX-1 inhibitors. Oftentimes, they're better at relieving inflammation and pain than COX-1 inhibitors and cause less gastrointestinal distress. Keep in mind that most medications, whether it's classified as an NSAID or a COX-2 inhibitor, are going to have effects on both COX-1 and COX-2, just to differing degrees. Now, by blocking COX-1 or COX-2, the idea is to block that arachidonic acid cascade from stimulating the production of prostaglandins. Prostaglandins have many effects on the patient's body, listed in the box on page 10. They activate inflammation. Okay, now again, remember, inflammation in the body is good. This is a thing, a mechanism, by which the body will help to repair areas that have become damaged. It's a mechanism that helps to replace tissue that has become old. So it's important that we have inflammation. We just want to control it in certain parts of the body. For example, your patient who has osteoarthritis, we may want to control that inflammation in order to decrease pain and increase mobility of certain joints. Other effects of prostaglandins are to cause vasoconstriction or vasodilation. Now remember, I mentioned before that there's three main components of the inflammatory process: vasodilation, capillary permeability, and clotting. You'll notice that some of these are effects of prostaglandins. Now, prostaglandins can have an effect on the vasculature in a couple of different ways. They can cause vasodilation from an external stimulus. From an internal prostaglandin stimulus, they can cause vasoconstriction. This is one of the mechanisms we think works in a patient who has atherosclerotic disease. Your patient who has atherosclerotic coronary disease has possibly some vasoconstriction being caused by prostaglandins as part of that inflammatory process of atherosclerosis around the heart. So the patient has a narrowing of the vessel and then develops ischemia, injury, and necrosis of the heart due to vasoconstriction that occurred because of this prostaglandin stimulation. That's why many patients will come to the hospital having unstable angina or having a myocardial infarction, and in fact, they don't have complete occlusion of their vasculature. Maybe they have 60% or 70 or 80% occlusion of the vasculature. But some vasoconstriction can totally occlude the vasculature, and it's caused by prostaglandin inside the vessel. Platelets can be activated and inactivated by prostaglandin. Again, this is due to the functions within and outside of the blood vessels. So depending on where the stimulus is coming from, will depend on what kind of stimulation we have, whether we have clotting occurring or whether we have bleeding occurring. This is one of the mechanisms that could be responsible for the production of and the formation of DIC. Prostaglandin is also important for producing the gastric mucosa, which protects the stomach from the acid that is being produced and pumped into the stomach. Prostaglandin is responsible for renal blood flow and also for bronchoconstriction. Now that we know some of the effects of prostaglandin in the body, and knowing that our nonsteroidal anti-inflammatory drugs will block these effects by blocking COX-1 or COX-2 in the arachidonic acid pathway, we can start to understand some of the side effects and adverse effects we get with nonsteroidal anti-inflammatory use. First of all, it decreases inflammation. Now, this is a good thing. In many cases, we want to decrease inflammation. If you sprain your ankle, taking Advil will help. Not only does it help to block the pain, but it has a fairly strong response against inflammation. Prostaglandin, although it's not listed as one of the effects on your list there, prostaglandin stimulates pain receptors. On a local level, decreasing prostaglandin synthesis will help to decrease pain perception. So using our nonsteroidal anti-inflammatory and blocking that arachidonic acid pathway and blocking prostaglandin synthesis is going to be helpful in decreasing pain and in decreasing inflammation. Go back to your patient with arthritis. The patient with arthritis may find long-term relief by using nonsteroidal anti-inflammatories because they continue to block that inflammatory stimulation. Okay, now keep in mind that in diseases like osteoarthritis, the patient has a chronic stimulus, probably autoimmune, that is causing the patient to have a chronic stimulus of the inflammatory process. Therefore, we're going to have chronic nonsteroidal anti-inflammatory use in order to be able to combat this. So taking a couple Advil is not going to stop the process. It's just going to temporarily relieve it. It's not a cure. It's relieving the symptoms temporarily, possibly decreasing the progression of the disease temporarily. Okay, well, what can some of these other effects cause for our patient? If we give a nonsteroidal anti-inflammatory, it can possibly cause vasodilation or vasoconstriction in the patient's body. Could this be the mechanism by which patients who receive nonsteroidal anti-inflammatories have a higher risk of cardiovascular disease and death from cardiovascular disease? We don't know. Obviously, a lot was said about the COX-2 inhibitors and their role in death from cardiovascular disease. So far, the theory is that it's a combination of this vasoconstriction and platelet activation that occurs when we use nonsteroidal anti-inflammatories that increases the risk of cardiovascular disease and cardiovascular death. But the jury's still out. We don't know yet. We don't have enough information. Anticipate that those studies will continue for the next few years before we see a lot more recommendations about not giving NSAIDs to patients who have cardiovascular disease. Production of the gastric mucosa is also regulated by prostaglandin, and if we're blocking that regulation, then the patient is not going to develop that gastric mucus, which protects the stomach from the acid inside the stomach. Okay, now keep in mind that the stomach is always producing acid. This is on a continuous basis. And we're always pumping that acid into the stomach so that it can be used to help to break down food in the beginning of the digestion process. If we give our patient a non-steroidal anti-inflammatory, though, it will block that prostaglandin synthesis, block that gastric mucus production, and can open up or expose the stomach lining to the acid inside the stomach. This is what produces some of the side effects of non-steroidal anti-inflammatories, including GERD, heartburn, and other types of GI symptoms. Unfortunately, the results can be much more devastating. GI bleeding is common with the regular administration of non-steroidal anti-inflammatory drugs. Okay, and here's the mechanism. You see the mechanism there? The mechanism is we're blocking prostaglandin synthesis, which is responsible for gastric mucus production. And the patient develops a GI bleed. Now keep in mind that when patients are using NSAIDs, oftentimes they're using more than one. It's great that you can buy this stuff at the pharmacy over the counter. Certainly, if you sprain an ankle, you don't want to have to go to the doctor's office just to get a prescription for an NSAID when you could drive down to the pharmacy and pick up a bottle of Advil. On the other hand, as you're strolling down that aisle, I guess since you've got a sprained ankle, it's limping down that aisle, you're going to notice that there's lots of different NSAIDs. Now, if you're not a healthcare practitioner, you may not know the difference. They all say on them, non-aspirin pain reliever. What's the difference between Advil, Nuprin, Motrin, generic ibuprofen, etc.? Well, to many consumers, they're all different, and they all work different ways. So they may go to the store and buy 3, 4, 5 of these and take them all at the same time, thereby increasing their risk of a GI bleed. Now, the COX-2 inhibitors, because they're working on a slightly different mechanism in the arachidonic acid cascade, are supposed to produce less GI bleeding than do COX-1, the traditional non-steroidal anti-inflammatories. However, the studies were not done looking at COX-2 inhibitors when they're used concurrently with NSAIDs. Well, why would that matter? Think about the people who are taking these medications. Aren't they patients who have arthritis and other kinds of chronic pain situations? Those are the kind of patients that are probably running down to the drugstore and they've got some Advil and some Nuprin and some Motrin and all that other kind of stuff in their cupboard as well. We had one patient who developed a GI bleed, just vomited 1,000 cc's of bright red blood. Wondering where this patient developed his GI bleed from, we asked him if he took any non-steroidal anti-inflammatories. He denied it, but of course his wife said, well, of course, he is on 2 prescription NSAIDs, one of them was a COX-2 inhibitor, and 3 over-the-counter NSAIDs that he's taking on a regular basis. Well, why not? You look at the back of the bottle of Advil, it doesn't say don't take this with Motrin. Okay, so our patients may not know. And this could really lead to some dangerous situations in our patient. How about the next action of prostaglandin? Regulation of renal blood flow. This is the mechanism by which NSAIDs can cause a patient to develop nephrotoxicity. Prostaglandin regulates renal blood flow by causing vasodilation of the renal artery. Now, the renal system has its own blood flow regulation mechanism. So your patient may have, let's say, high blood pressure, for example. Prostaglandin helps to regulate the vasculature inside the kidney to maintain vasodilation so that that hypertension does not cause damage to the inside of the kidney. In this way, you can have different blood pressures as you go throughout your day, and the renal blood flow will remain constant. Part of this is regulated by prostaglandin. Now, when we block prostaglandin by giving nonsteroidal anti-inflammatories on a regular basis, what can happen is that we can have vasoconstriction in the kidney, which limits the amount of blood flow going to the kidney and causes a pre-renal type of renal failure or nephrotoxicity. NSAID-induced nephrotoxicity is dose-dependent and time-dependent. In other words, your patient can take large doses of NSAIDs for a short period of time and not cause nephrotoxicity. A patient who is on a large dose for a long period of time is likely to produce nephrotoxicity. Take a look at your patient's underlying renal function and understand that renal function is not a black and white thing. Our patients do not have good renal function and bad renal function. Everybody has a limitation on their renal function. Nobody really has 100% renal function. We're all on a continuum. And we're somewhere along that continuum between maybe 99% and say like 26%. Somewhere on that continuum and still have normal BUN and creatinines. The BUN and creatinine don't even start to rise in your patient until your patient has lost 75% of renal function. So don't look at the BUN and think, well, the kidneys must be okay because the BUN isn't rising yet. All right, that won't rise until we've down to 25% of our renal function left. Okay, so in other words, we have to consider where our patient is along this continuum. And everybody has some form of decreased renal function. So how do you know? There's a couple things you can do. One thing is you can take a look at the patient's age. The older the patient is, the more hits the patient has on the kidney. That's one way to tell. Second way to tell is to look at your patient's estimated creatinine clearance. Now, one way to get creatinine clearance is simply to do a 24-hour urine. The other way is to use a formula called the Cockcroft formula. The Cockcroft formula estimates your patient's creatinine clearance based on the patient's creatinine level, their age, and their weight. So look at your patient's renal function as being on a continuum and evaluate where your patient could be before we give that patient any recommendations to use nonsteroidal anti-inflammatory medications, especially in large doses or for a long period of time. One more mechanism of prostaglandins is that they can cause bronchoconstriction. So the production of prostaglandin helps to maintain bronchoconstriction in the patient. Well, you may think, well, geez, that's not a good thing. We want to have bronchodilation. A patient who has been taking nonsteroidal anti-inflammatories for any length of time may have developed vasodilation as a result of the blockage of prostaglandin. Okay, now let's just take, for example, here for a moment, let's think about this. And if your patient maybe is an asthmatic or COPDer, and that patient has been on a nonsteroidal anti-inflammatory for a long period of time, but today develops a GI bleed, we're probably going to stop the nonsteroidal anti-inflammatory. Now, what else could you expect to see in that patient? Yes, you may see bronchoconstriction, because now we have the effects of prostaglandin that were being blocked before. Okay, so that's something to consider. Well, what do you do with a patient who develops a GI bleed and needs a nonsteroidal anti-inflammatory? You got that patient who has osteoarthritis and the patient's got considerable pain and the patient's been on NSAIDs and been on COX-2 inhibitors and all that kind of jazz, and the patient develops a GI bleed. What do? The recommendations are that we stop the NSAID and possibly start the patient on a COX-2 inhibitor along with a proton pump inhibitor. Now, proton pump inhibitors are very strong acid reducers. These are medications that are going to block that proton pump in the stomach lining, and that's the thing that's pumping acid into the stomach. So they're a very strong acid reducer, much stronger than our H2 receptor antagonists. and they will do a much better job at decreasing the amount of acid in the stomach. And then the patient would be placed on simply the COX-2 inhibitor to try to decrease the inflammation associated with that arthritis. Another medication that helps to decrease inflammation is corticosteroids. Now, corticosteroids, again, I don't want to give you the misinterpretation here of thinking about steroids as being like the anabolic type we hear so much of with our athletes. Corticosteroids are a naturally forming substance in the body. What we do is we give the patient corticosteroids, either orally, IM, or IV, so we give an external source of corticosteroid, which is going to cause some of the same responses it does in the body. Some of the things that steroids do are to decrease T-cell formation and migration. Now, this is one of the major things that helps to fight off bacterial infections, is T-cell formation and migration. If we're not forming the T-cells and they're not being able to migrate to the sites in the body where that infection is, we're not going to be able to fight that infection. Secondly, they will decrease prostaglandin synthesis. Okay, again, we just talked about that and all the different components involved in that. So we're going to have all of those negative consequences that we saw along with the non-steroidal anti-inflammatories. So long-term steroid therapy can cause your patient to develop GI bleeds, it can cause the patient to develop renal dysfunction, and it can cause that patient to have vasodilation or vasoconstriction and platelet aggregation, which could cause some additional cardiovascular events. Next, it decreases leukotrienes. Now, leukotrienes are another part of the inflammatory process. So by decreasing leukotrienes, it's going to have an effect on the inflammatory process from a different angle. Decreases the function of macrophages. Macrophages are white blood cells that travel out into the tissues of the body in order to eat up bacteria and to eat up cellular debris. Their functions are kind of like little Pac-Men. They run around the body eating up the stuff that we want to try to get rid of. Lastly, it impairs the action of B cells. Now, the two major precursors of all of the white blood cells that we have in the body are T cells and B cells. Notice that steroids decrease both T cell and B cell formation, migration, and action. That means your patient is going to be at an increased risk for infection. Now, before we start talking about some of the other side effects of corticosteroids, one thing that's very important to know is because we're blocking so much of the inflammatory process here, that if your patient does become infected, you may not know it. When a patient is taking steroids, it blocks so much of the inflammatory process that your patient may not develop a fever, may not develop sputum or drainage, may not develop an increase in white blood cell count. Now, can you see why? We're blocking both B cell and T cell formation, migration, and action. So we may not get that initial rise in white blood cell count that we would anticipate as being a sign of infection. So where our patient is now more at risk for developing infection, and we're going to have a harder time finding it. Some of the other adverse and side effects we get with corticosteroids include osteoporosis. Corticosteroids interfere with the movement of calcium into the bone and actually allow more calcium to leave the bone than enter the bone. Because of the blockage of prostaglandins, we can get gastric ulcers. We can have problems with hypokalemia as we're dumping out potassium to the kidneys. The patient can develop hypertension, edema. Okay, now these are functions of that blockage of prostaglandin causing impaired blood flow and impaired renal perfusion. Hyperglycemia, because corticosteroids block the reuptake of glucose. So they cause an increase in glyconeogenesis in the liver, making more glucose, and they block some of the reuptake of glucose back into storage. Impaired wound healing occurs because the inflammatory process is necessary for wound healing. Okay, remember we talked about that part already. You get a cut on your hand, what helps that to heal up? The inflammatory process. We need to have vasodilation, capillary permeability and clotting occurring there. And then what's the end result of inflammation? Scar tissue formation, right? So by blocking our inflammatory process by using corticosteroids, our patient is going to have impaired wound healing. Now, why don't we see as much of this problem with non-steroidal anti-inflammatories as we do with steroids? Because steroids block so many different parts of the inflammatory process. See, our non-steroidal anti-inflammatory is primarily working on blocking that thing that causes the prostaglandin formation. Corticosteroids do that plus a whole lot more. We can also see emotional lability in our patient on corticosteroids, and that is oftentimes the reason why some patients would have to have therapy discontinued. Probably the most life-threatening side effect or adverse effect we can get from corticosteroid administration is what happens when we stop giving the steroid. Now you see, corticosteroids are produced by the kidney, and the adrenal gland will produce corticosteroids for the body. When we give steroids from an outside source, the body stops producing them. And then if we stop those corticosteroids abruptly, what can happen is that the patient develops a deficiency. And this deficiency is what we call adrenal insufficiency. Now, corticosteroids, we talked about the actions that they have on the immune system and on the inflammatory system, but they also have a variety of other functions in the body. And if we stop that corticosteroid suddenly, what can happen is the patient goes into an adrenal insufficiency. How are you going to find adrenal insufficiency in your patients? Look for three things: bradycardia, hypotension, and weakness. Bradycardia, hypotension, and weakness. Wait a minute. Bradycardia and hypotension? Those two things don't go together. What's supposed to go along with hypotension? Tachycardia, right? Ah, that's one way you can find it. Bradycardia and hypotension, they don't fit. So think about the possibility of adrenal insufficiency. What happens a lot of times is we see a patient who has bradycardia and hypotension, and we automatically assume it's got to be the cardiac medication, doesn't it? So we go right on down the list and we hold all of that patient's cardiac meds. Now, if this is adrenal insufficiency, first of all, that's not going to treat the problem, and it could potentially open that patient up for having a cardiac event. That patient needs those cardiac meds. So how would you know the difference? Well, geez, if this patient's been on that beta blocker for 5 years, it's not the beta blocker, okay? Start looking a little deeper. All right, so maybe we're assuming, maybe we're thinking here, okay, maybe it's adrenal insufficiency in this patient. Because the patient's on cardiac meds, but she's been on them for 5 years, so it's probably not the cardiac med. How do we know? Look for the steroid. Okay, what do I mean by that? Look for the steroid use. Let me ask you, what kind of patients take steroids? Think about some patients that take steroids. Your patient with asthma, your patient with COPD, who else? Your patient with osteoarthritis, your patient with an autoimmune disease, like lupus, your patients who have chronic inflammatory bowel diseases, right? These are the kind of patients that you can anticipate might be on a steroid. Now, if you notice this morning your patient's got bradycardia and hypotension, then we got to be thinking about the possibility it could be adrenal insufficiency. Look for the steroid. Should this patient be on a steroid and the patient is not? Maybe the patient was on a steroid at home and it didn't get ordered here in the hospital. Maybe the patient was on a steroid over in the ICU and now the patient was transferred to your floor and they forgot to write for the steroid. Remember again with medication reconciliation, that's the whole idea. We're trying to catch this stuff so it doesn't get just transferred, from one floor to the next and we miss it. Now here's another situation where the patient could have developed adrenal insufficiency from a steroid. How about your COPDer? Now many COPDers and asthmatics nowadays are on inhaled corticosteroids. Now inhaled corticosteroids should not develop a blood level, provided that they're taken as directed. But think about your COPDer. When your COPDer can't breathe, they grab every inhaler they can and they use it till they feel better, right? We had a patient come into the emergency department with the bag. You know what I mean there, right? Yeah, that big bag full of empty canisters and containers of medication and everything else. I think they save them up from like the last 5 years. But the patient's got this big bag full of stuff, right? And pulls out the inhaler, and I asked the patient, how often do you take this inhaler? Well, 2 puffs twice a day. Now, the inhaler was filled on Monday, and today's Thursday, and it's empty. So how often have you been taking it lately? Well, a little bit more because I couldn't breathe. Obviously a little bit more because you used a 30-day supply in 3 days. All right? Now this patient is going to have a blood level of corticosteroid from all of that inhaled steroid. But think about how that history is going to get related to the physician. The doctor's going to ask the patient, how often do you use your asthma cord? And the patient's going to say, 2 puffs twice a day. So in the hospital, the patient will be placed on asthma cord 2 puffs twice a day, when in fact the patient was using it at home 30, 40, 50 times a day. So the patient had a blood level. Now in the hospital won't have a blood level. The patient could potentially develop adrenal insufficiency. So look for the steroid. This is the way that we would find this problem of adrenal insufficiency. The third classification of medications that modify the immune system are our anti-rejection medications. There's a list found on page 12 in your handout. As a general rule, anti-rejection medications are going to decrease both the immune and inflammatory responses so that the patient won't reject whatever organ was transplanted. Now, when we transplant an organ into a patient's body, that is a foreign body, and that patient's body will try to do something about that. In the same way that if you get a splinter in your hand, the body tries to reject the splinter. The body is going to try to work the splinter back out of the body. So it may help to, initially it may just kind of wall it off, and scar tissue, etc., may help to try and push it back out. Over time, the inflammatory process may start to break it down and actually take that splinter apart. White blood cells like macrophages may kind of eat it up and it disappears. The body is going to do the same thing with a transplanted organ. It's going to recognize the fact that it is not part of the patient's own body, no matter how well we match it up. The body's still going to recognize it's not a part of. And there's going to be some inflammation and some immune response to try to destroy that thing that is not a part of the body. So how do we control this and keep the patient from rejecting or having an out-of-control inflammatory immune response that is going to destroy this transplanted organ? We give anti-rejection medications. So in other words, these medications are medications that are designed to either hold off or stop the immune and inflammatory processes in the patient's body. So right off the bat, you know something about these things. If they are stopping inflammation and immunity, then isn't a major side effect going to be infection? And in fact, that is one of the major side effects we see. Like corticosteroids, because these medications modulate inflammation and modulate the inflammatory response, we may not see typical signs of infection in these patients. These patients may not mount a fever. They may not have changes on their chest x-ray indicating pneumonia. They may not develop sputum or develop drainage, and their white blood cell count may not elevate. In addition, as a general rule, these medications are both nephrotoxic and hepatotoxic. Any patient on any anti-rejection medication should carefully be monitored for changes in both renal function and liver function. Lastly, these medications tend to suppress the bone marrow and the production of new red blood cells, white blood cells, and platelets. So as a general rule, watch for decreases in these counts. Watch for anemia. Watch for a very low platelet count that could cause spontaneous bleeding in your patient. Now you'll notice that this chart on page 12 lists a lot of different side effects as the result of these anti-rejection medications. Well, goodness, how are you going to remember all that? And take a look in your pocket reference, and there's a card for anti-rejection medications, and it gets down to just a couple things about each one of these medications. So this is probably a better way to remember them. These are the things that are very specific.